The following podcast is part of a certified educational activity titled A Bold Frontier, Shattering the Limits of Conventional Therapies and Reshaping the Future of Lung Cancer Treatment with TROP2-Targeting ADCs and Rational Combinations. Access the entire activity and complete the post-test at peerview.com/WFX860. Downloadable slides and practice aids are also available.
Welcome to this PeerView CME event held in conjunction with the World Conference on Lung Cancer 2023, approved by the ISLC. My name is Dr. Stephen Liu from Georgetown University in the U.S. And today we're going to talk about shattering the limits of conventional therapies, reshaping the future of lung cancer treatment with TROP2-Targeting ADCs and rational combinations. For this one-hour program, I am joined by two esteemed colleagues with a wealth of experience in this area. From Yonsei University College of Medicine in Seoul, South Korea, Dr. Sun-Min Lin, and from University of Las Palmas de Gran Canaria, Dr. Delvis Rodriguez Abreu. Welcome to our two co-panelists. Our goals for today are to augment your knowledge of TROP2 and TROP2 targeting ADCs or antibody drug conjugates in lung cancer to improve your awareness of the monotherapy or combinatorial treatment strategies with these antibody drug conjugates in lung cancer and some of the emerging clinical data, some of which will be presented later at this meeting, and to learn how to integrate TROP2 targeting ADCs into the treatment plans of appropriate selected patients with lung cancer and manage some of the adverse events. And so let's jump right into the discussion, talking about fundamental concepts of antibody drug conjugates. Now, I see some familiar faces in the audience that really are focused on lung cancer. Antibody drug conjugates are relatively new to the lung cancer world, but we use them throughout oncology and other disease types like breast cancer, like bladder cancer. All right, this is a meeting for lung cancer, and I think as everyone in this room knows, the treatment paradigms for non-small cell lung cancer have dramatically shifted. They resemble almost nothing what we were doing 20 years ago. This treatment is guided by biomarkers, and the presence of an actionable alteration directs us towards targeted therapy, directs us away from immunotherapy. This has changed what we're capable of in lung cancer. We can see fast, dramatic, and importantly, durable responses. But the challenge here is resistance. And as good as our outcomes are, there's still a lot of room for improvement. We still face challenges with intrinsic resistance. Our response rates are not 100%, in many cases far from it, and acquired resistance. Even when we get responses, they don't last, they're not forever. When we see resistance emerge, our options there, unfortunately, remain pretty limited. For all the advances we have, when patients progress on immunotherapy or targeted therapy, the majority of those patients turn to cytotoxic chemotherapy, agents that we're familiar with that have their own toxicities and unfortunately pretty low ceilings on what they can achieve. Question we have looking forward in the field, can antibody drug conjugates fill these existing practice gaps? Well, antibody drug conjugates, the class of medicines, I think it's important we understand how they work. And I'm going to turn it over to Sun-Min. Can you walk us through the structure of what ADCs are?
Yes. So thank you. So I'd like to walk us on how getting to know the antibody structures. So ADC is composed of three key structures, but most importantly, the antigen is required for the antibody to bind. So the ideal antigen is highly homogeneous, expressed in the tumor, but not expressed in the normal tissue. And when the TROP2 antigen is expressed in the tumors, antibody targeting TROP2 can bind to that antigen. So the antibody has to have a very high affinity and avidity for the target tissue, target antigen, and needs to have a long half-life to stay in the bloodstream. And also the conjugation sites should have a minimal impact on the ADC stability and internalization and pharmacokinetics. So moving on to the next structure is the drug payload. This is a very important topic here. So as previously dealt in the question, the payload is not TROP2 directed. The payload is the chemotherapy component that is highly potent, it's like a bomb in the cell, as a microtubule inhibitor or DNA damage agents that are able to induce apoptosis in the cancer cells. Payload needs to be stable because we don't want off-target effects in the bystander issue and demonstrates a local bystander effect. And as we'll be dealing with Elvis later, this is a maximized drug-to-antibody ratio.
Yeah, so we have the antibody that's targeting the certain antigen that we want expressed on the cancer cells. We have this payload that for now is a cytotoxic agent, though in the future it could be many different molecules, small molecules, immunoconjugates as well. Now, what we're showing here is a simplified representation. This is an antibody, this is a payload, but the details here are really important. It's one of the things we're learning about antibody-drug conjugates. These small changes make a big difference. Now, Delvis, it's not as simple as this. We don't have an antibody with two little arms that are the payloads, right? There's a little more complexity to that, right?
Yes, Stephen. The first one is to say, are you sure that it's a new kid in the block? Or is it too old?
That's right.
No, it's right, because ADC is not new. In gynecology, in breast cancer, it's usually now. But as you say, so means that the payload is very important in ADC. But the amount of this payload is linked to the antibody is also very important. And there is quite that here these two antibodies are not anti-TROP, it's anti-HER2. But it's important to see, especially that some of them, the amount of payload, especially in the trastuzumab deruxtecan, is DAR 8. And we will see this. And why? Because the higher the DAR, the higher the possibility of efficacy. But we need to be cautious with this, because maybe the higher the DAR, the higher the toxicity. And there is some preclinical study that also said that if the DAR is so high, the clearance in the liver could be high also. So we need to find the middle, this rationale, the structural rationale, to have a high efficacy with a low toxicity with this antibody.
Yeah, we live in an era of medicinal chemistry and synthetic biology where all of these details matter. These are really elegantly designed structures. They don't stumble upon these different ratios, as you mentioned, a balance between more drug, but sometimes that does affect clearance. And so all these details matter. Now, we've left the third part to last, maybe the least glamorous part of the ADC, but maybe the most important, and that's the linker. Is this what the linker is something?
Yeah. So linker is like a glue. So we need a linker to connect the payload to the antibody. So the linker, there are two types of linkers. So first is a non-cleavable linker, and second is the cleavable linker. So non-cleavable linker, if a drug has a non-cleavable linker, it should be internalized and should be degraded in the lysosomes only. So in contrast, cleavable linkers can be degraded under acidic conditions or could be lysosomal sensitive. So in theory, cleavable linkers can induce more bystander effects. However, most agents that are developed so far have cleavable linkers. So we'll need to see the toxicity profiles.
Yeah, so these linkers, we don't want one that's too weak that releases this topoisomerase inhibitor or DNA damaging agent. We don't want it so strong it doesn't release it at all. We're going to look at these ADCs in general. As we mentioned, there are a lot of details that matter. The antibody, the linker, the cytotoxic payload here. For the case of TROP2, largely topoisomerase inhibitors. So Delvis, can you walk us through a little bit of the antibody drug conjugate mechanisms of action in general?
Yes, you're completely right, because it's not so simple. And my question is, do we have to refer to ADC as a simple chemotherapy? Because one of the mechanisms of action of ADC, of course, as you say, some mean with the payload is chemotherapy at the end. So one of the mechanisms of action is just due to the chemotherapy that is high potent, is more potent than the usual chemotherapy that we use to treat cancer patients. But maybe it's also the mechanism of action related with the target then taken. I think it's both, and clearly it's both. First of all, the antibody link attached to the antigen, and of course can block the activity of this pathway in the receptor, but also internalizing the cells and then can release the payload, and the payload in some case, like in sacituzumab, we'll be talking about that, is 1,000 more potent than irinotecan. We will talk about that. So we are giving the drug inside the cell with high potency that can release, can destroy the cell, and then there's another mechanism of action because when the cell is destroyed, this payload, this chemotherapy can damage the surrounding cell, even if they don't have the but there is another mechanism of action. We were talking about antibody, especially EG1, that can have an active FC region that can link, can activate ADCC, antibody-dependent cell cytotoxic, and can stimulate the immune system. And it's another way how ADC works.
So directly cell killing, the bystander effect with neighboring cells, but maybe this potential synergy with immunotherapy. And I think we're just scratching the surface on the potential for these drugs. We've got a lot of ADCs in development for lung cancer on the left. Here we see our HER2 antibodies, trastuzumab emtansine in our NCCN guidelines in the US. The trastuzumab deruxtecan, our FDA-approved drug for HER2 mutant lung cancer. Others in development, we see for HER3, we have patritumab deruxtecan. On the far right, we have IDXD and MGC018 looking at B7H3 in small cell lung cancer, telisotuzumab vedotin for MET overexpressed lung cancer, and of course, right there in the middle, what we think will have a major impact for non-small cell lung cancer will be our TROP2-directed antibody-drug conjugates, sacituzumab govitecan, datopotamab deruxtecan. They are fun drugs to say, so I encourage you to practice saying them. These are fun words. We've got a lot of them in development, a lot of different developmental strategies. This is just a list. You can download these slides for your own reference, but our focus today is on TROP2. And while there are other TROP2 ADCs in development, these are the two that are furthest along, that are most likely to impact our care. On the left is sacituzumab govitecan. On the right, datopotamab deruxtecan. Both of these ADCs targeting TROP2, both being developed in the non-small cell lung cancer space. Sacituzumab govitecan we know is approved for breast cancer, for urothelial cancer, no approvals yet for datopotamab. These drugs, though, are very different, and we're going to talk about some of these differences today. The differences are more than just the colors. We know Sassy is blue and Dato is orange, right? So beyond the color, there are a lot of other details that are different. So let's talk about some of these data.
TROP2 was initially, I think it was more simplest that it is right now because it's just transmembrane protein that activate, especially not only the calcium intracellular cancer signal that it was at the beginning we thought that, but we know right now TROP2 is another adjacent protein like claudin and other that finally promote proliferation of the cell and evolution of the tumor cell because it's not only this kind of addiction but also betaine, kinase protein, and all those things that finally produce a proliferation and metastasis of the cell. And especially, we know right now that TROP2 initially was related with the development in the brief genesis. But right now, TROP2 is related, we can find it in a lot of tissue. And not only in tumor tissue, but also in healthy tissue. And we have to keep into account because we have to focus in the toxicity at the end. And we want to talk about that. So, the next. So we know also that as a transmembrane glycoprotein, TROP2 is highly expressed in lung cancer. In non-squamous non-small cell lung cancer, it is around 64% of the patient, the expression of TROP2. But in squamous could be up to 75% of the patient. And we know that the higher expression of TROP2 in the tumor cell, as you can see here, is a bad prognostic factor in lung cancer, and that's good. And we know it's good to know that because we know that this population with the high expression can respond to ADC in the future. We don't have currently recommended testing for TROP2, but we know that a lot of companies and pharma are doing that because we need to identify a better biomarker also for ADC. Maybe we can discuss Stephen.
We certainly want biomarkers, it's true, but because TROP2 is so highly expressed in lung cancer, especially in those that need the therapy the most, and because we are seeing activity, at least in models, in tumors that don't express IHC positive TROP2, right now these drugs are being developed sort of in an agnostic approach. Has that been your experience as well?
Yes, I think so. So The TROP2 antibody, the antibody is not exactly defined. There are many different types of antibody. We don't know which is the gold standard as of now. So most clinical trials are derived non-diagnosed biomarker tested.
That's right. So no biomarker selection yet. We'll work towards that. Here's an overview of some of the key trials for ADCs. And as we're about to talk about, we are really looking at all of those different strategies and more. We're trying to find the best way to use these drugs, leveraging their different properties and the different mechanisms of action. So let's start talking about these drugs in a little more detail. Delvis, can you tell us about sacituzumab govitecan?
Well, as you said, I'm very happy to share with you the information that we have up to now with sacituzumab govitecan in lung cancer. As you say, this antibody is an IgG1 antibody, and the payload is SM38. This is a topoisomerase 1 inhibitor, but it's a metabolism of irinotecan, but 1,000 more potent than irinotecan. And imagine that, because as I said, the DAR in this antibody is 7 or 8 payload per antibody. So the amount of chemotherapy that released in the tumor is very high, and the potency of this antibody it is. So we have some data in the phase 1/2 in this trial in the immune 132. We know that we included in this trial a patient with non-small cell lung cancer, but also with small cell lung cancer. And in the dose expansion, it was sacituzumab 8 milligram per kilo. It was 8 patients, and sacituzumab 10 milligram per kilo, 46 patients. Here you can see the response rate in this cohort of 54 patients was 16.7%. It is not bad, but because remember, it was in pre-treated population of patients, and it was independent of the pressure of TROP2. And the toxicity, it was more or less the toxicity that we are used to treat with chemotherapy. And this toxicity was nausea, diarrhea, fatigue, alopecia, neutropenia. I would like to emphasize that in interstitial lung disease, that is a very concern adverse event with antibody with sacituzumab was very low, and that's good. Even if the adverse event leading to dose reduction was 43% of the patient, almost all the adverse event was grade 1 and 2 in this phase 1/2. Of course, in this trial, we have to see the tumor response related with the overall survival. Well, it's very early, but you see here in the cohort of a small cell lung cancer, we know a small cell lung cancer is very sensitive to chemotherapy, but it's very resistant to chemotherapy also. So whatever we find for this disease is important, and we have here an overall response rate in all the population of 14%, and in the doses 10 milligram per kilo, 17%. Is not bad. Even if we are talking a stable disease, 42% of the patient stay in stable disease. In a small cell, it is a good thing. Around 1/3 of the patient with refractory small cell lung cancer after first or second line therapy gets some clinical benefit. So we have also that the toxicity in a small cell cancer, it was more or less the same. It was diarrhea, nausea, fatigue, neutropenia, vomiting, and the grade 3 adverse event was generally low. As I said before, grade 1 or grade 2. And it's nice because this kind of toxicity, we are used to treat this kind of toxicity with chemotherapy.
It's important that I think this is a really important point there, Dallas, because when we think about antibody drug conjugates, these are sort of directed. We think of them as targeted agents, but they're not targeted in the sense that we traditionally think of in lung cancer. A lot of people don't realize that the side effects align much more closely with chemotherapy. And so, like you mentioned, we can anticipate, we can treat diarrhea, nausea. We've gotten pretty good at that. We just need to understand and remember that we need to do that. If we give these drugs without proper medication, proper supportive care, toxicities can be notable, but with proper pre-medications, proper support, these are much better tolerated. These are things we're very comfortable with.
That's so important. We have to insist that education to the patient, education as we used to do with chemotherapy, but in this case, moreover, can help us very much to control the toxicity in this kind of drugs. So we have other trial, the TROPic-3. This is the study design. This is the use of sacituzumab at 10 milligram per kilo. But in this trial, in pre-treated population with platinum pre-treated population, PD-1, PD-1, but this trial is in the select elevate TROP2 population. That's I said. Because you are right, Stephen. TROP2 is high expressed in lung cancer. Are we still needing to get better biomarker? I don't know if it's TROP2. I don't know if something else related, but we still, it's very good trial. It's a phase 2 trial. We have the book 1. Everybody are waiting for the result. We're waiting because it's a phase 3 trial in patients with non-small cell lung cancer progressing after platinum or immunotherapy without driver mutation are randomized to sacituzumab govitecan 10 milligram per kilo day 1 and 8 every 3 weeks versus docetaxel, the standard of care. We're waiting because we need in this population. We know that immunotherapy changed the landscape of lung cancer, but a lot of patients are still relapsing, still with resistance of the disease. The BOC2 study design is a little bit complicated, but it's in first line. It's a phase 2 trial that with different cohort. The cohort A and cohort B is the combination of sacituzumab, pembrolizumab. The cohort A is the combination in PD-L1 more than 50% of the patient is in first line, and the cohort B is in those patients with PD-L1 less than 50%. That we know in this population the response rate is lower. And the cohort C and D is the combination of platinum, pembrolizumab, the standard of care, plus sacituzumab, that is the chemo finally, not with pemetrexed, not with paclitaxel, but with sacituzumab, and the cohort C is non-squamous and the cohort D is squamous histology. So we have this data is a little bit spoiler. You can see all the documentation, all the results of this presentation tomorrow, I think, in this Congress. But this is the extra, and we want to share with you some aspect. And in the cohort A, in patients with PD-L1 more than 50%, the response rate was 75%. It's very high, but keep attention, the number of patients is low. And the cohort B, in those patients with PD-L1 less than 50%, we are talking sacituzumab plus pembrolizumab without platinum, and the response rate is 44%. I just want to keep attention that the grade 3 and 4 adverse event was around 50% of the patient.
If we look at these data, so these will be presented tomorrow in the oral abstract session by your colleague from Yonsei, Byung Cho. Sunim, what's your take on this? I know these are just the abstract. We'll see the full data tomorrow, but your thoughts on these two cohorts with sacituzumab plus pembro frontline setting. What are your thoughts here?
Yes, Stephen. So we've had several patients enrolled in this trial at our center, and will be presented tomorrow afternoon by Dr. Cho. As for my opinions, that efficacy is encouraging in both PD-L1 high and low patients, and given that even PD-L1 0% patients were involved in the PD-L1 low entity, so the response rate of 44% is encouraging. And particularly, we need more long-term data to see the durability of response and the progression-free survival and the survival data. And also the toxicity data is not confirmed yet, so we need to wait for long-term data.
Yeah, these response rates are high, I think, but we'll see what the full data set looks like and see these other data sets.
Yeah, but at least it is clear that there is a good relation we can check. Yeah. We can combine, and the combination work. We have to wait, but at least it's good. It's provocative, good number of patients with response. Well, the other trial is the BOC3, the Kino D46. It is also a phase 3 in first line with patients with PD-L1 more than 50%. And we know that the standard of care in those patients with PD-L1 more than 50% is pembrolizumab monotherapy. And this trial is very interesting because it is sacituzumab plus pembrolizumab versus pembrolizumab. It's a phase 3, and we are waiting to see if it can beat the pembrolizumab result. The other trial is velocity lung. It is not a combination with platinum, it's not a combination with pembro, but it's another combination with others immunotherapy. It's similarlimab, it's anti-PD-1 with domvanalimab, anti-TIGIT. We're combining the ADC with others immunotherapy compound. I think it looks promising also. The RB is also the combination with the dual adenosine receptor antagonist that we know we have a trial presented this year in ASCO with the data in phase line. Well, we need to wait, and we want to see this result.
So there's another TROP2 antibody drug conjugate in development for lung cancer, and it's datopotamab deruxtecan. So I'm going to ask you to walk us through a little bit about this structure and some of the early data we've seen with this drug in lung cancer.
Okay, so next drug is the datopotamab deruxtecan. So you can see, as you see the structure in the figure, you will see the deruxtecan derivative linked to the cleavable tetrapeptide-based linker and a humanized anti-TROP2 IgG1 monoclonal antibody. It has a DAR of 4. You can see the 4 payloads in red, and the payload with the short systemic half-life and the tumor-selective cleavable linker. So Tropion Pan-Tumor 01, this is a study design which tested the first activity at the safety of this datopotamab. So in the dose escalation trial, interestingly, they only enrolled non-small cell lung cancer in this escalation cohort. Datopotamab was tried from 0.27 milligrams per kilo to 10 milligrams per kilo every 3 weeks. MTD was established at 8 milligrams per kilo, and later on, dose expansion of non-small cell lung cancer cohorts at 3 different doses, 4, 6, and 8. The primary endpoints were MTD and safety, and you can see the anti-tumor activity of Dato-DXd in the non-small cell lung cancer cohort. You can see that across the dose levels, efficacy is consistently seen in the waterfall plot. And the median duration of response was 10.5 at 6 milligrams per kilo. And you can see the spider plot on the right bottom. You can see that all those levels achieved remarkable tumor shrinkage in the beginning. Going on to the safety, overall manageable safety profiles, and some AEs specifically to note is nausea, stomatitis, and alopecia, fatigue, vomiting. So these are typical AEs that arise from cytotoxic chemotherapy, as we have experienced so far. The serious grade 3 or higher events were noted in about 20% to 35% of patients treated. And of note, ILD, educated as drug-related, was noted in about 5% to 9%. And the Tropion Pan-Tumor 1 also included the actionable genomic alteration harboring patients, such as EGFR and ALK. So this is a very interesting finding, because after failure on osimertinib, this drug can work on these patients. So clinical activity was observed in EGFR mutant positive non-small cell lung cancer harboring exon 19 deletion, L858R mutation after failure on osimertinib. And now we know that Tropion Lung 01 is ongoing in the second line. This is to compare Dato-DXd versus the current standard of care, which is a docetaxel. And the primary endpoints will be PFS and the OS. Going on to Tropion Lung 02. So this is, as Delvis mentioned before, now they're combining pembrolizumab with Dato-DXd here. So there are 6 cohorts. They enrolled advanced non-small cell lung cancer, and they also allowed prior treated or treatment-naive patients. And cohort 1 and 2 studied the doublet combination. So Dato-DXd plus pembrolizumab and 2 different doses of Dato, 4 and 6. Cohorts 3 and 4, they combined Dato-DXd plus pembrolizumab and carboplatin. Cohort 5 and 6, they combined Dato-DXd plus pembrolizumab plus cisplatin. So the primary objectives were to look at the safety and tolerability in the doublet and the triplet regimens. So as previously presented by Dr. Goto this year's ASCO, this is the efficacy of this trial. So they did not specify the efficacy according to the dose levels, but they described the efficacy in doublet and triplet combinations. So you see that the doublet population, they showed the objective response rate of 38%, and the triplet population 49%. So the efficacy goes up when we combine chemotherapy. The duration of response was not reached at the time of cutoff. And you can see in the waterfall plot that the blue boxes represent the doublet, the red boxes represent the triplet combination. They all seem to have nice tumor shrinkage. And this is the efficacy in the first-line setting. So what about the first line? As you recall, in the sacituzumab plus pembrolizumab, here, the doublet combination showed the objective response rate of 50%, and the triplet combination had 57%. And the duration of response was pretty durable, but disease control was achieved in almost 91% in both doublet and triplet. So what about safety? So in this trial, treatment-related AEs occurring in more than 20% of patients are depicted in these bar graphs. And if we see those red boxes in triplet combination, we can note that hematologic toxicities increase a lot in the triplet therapy, such as anemia, thrombocytopenia, neutropenia. And I think these suggest that we need appropriate measures and preemptive measures maybe in the dealing with the hematologic toxicity. And also, the AEs of special interest are notable. So oral mucositis, stomatitis, these are fairly common, occurring about more than 50%. And also ILD, pneumonitis, adjudicated as drug-related, occurred about 70% in doublet and 22% in doublet. And the ocular surface toxicity and infusion reaction. So now we will have new data coming up tomorrow. This is a TROPION-Lung04. The study design is very complicated. So I'll let you follow tomorrow. But from cohort 1 to 4, they analyzed 2 cohorts in the abstract. So the efficacy in the first line. So the cohort 2 and 4, they showed the response rate of 50% and 76%, respectively, with the safety summary showing as below. So, okay.
So if we look at these frontline data, what's your impression here? Again, we'll see this tomorrow at WCLC 23 oral abstract session on ADCs. What's your initial impressions just from the abstract?
So Stephen, again, we are trying to move quickly to the first line, the combination with ADC and immunotherapy. And it probably it will work. I'm sure of that. And you can see the result, the response rate is even higher in the cohort for the combo. But again, the number of patients is low. It's a small number of patients. And we have to keep in, we have to wait to have more time to the follow-up, also to see the toxicity. Because up to now, the combination of platinum-based chemotherapy with pembrolizumab, with another, or Nivo plus EP, or the rest, can produce, we know how they work, we know that after 5-year follow-up, that a lot of people are still alive and without an increase of toxicity. And here, we need to be cautious, that's what I said, but I'm happy to see that the combination worked.
These data are coming fast, and it's good to see activity. Clearly, these are active drugs, and we're adding efficacy to them. We're getting a lot of questions in there, so I'll encourage people to keep asking questions. One of the questions has to do with endpoints for these studies. I think it's very relevant to these initial results. What we're seeing now with these early readouts is response rate. And response rate can be helpful for patients that are symptomatic up front. Our question, though, long-term Is that all these drugs are doing? Are they just adding additive benefit, or are we really seeing synergy? And for that, I think we need more long-term survival. It's good to see better response rates. What we really want is longer survival. And because of the way these drugs work and interact with our immune system, because of different mechanisms of action, there may really be a synergy which might allow us to get more durable responses too. And so those data aren't here yet. I'm surprised we've got so much data already to see, but clearly active drugs. Okay, so let's talk about practically how we integrate these. Here's a case, one of our patients, a 72-year-old male, former smoker, found to have a right middle lobe lung mass. Gets this PET scan that you see here. We've got that lung mass, we've got regional adenopathy and bone metastases. Biopsy shows squamous and adeno features, no actionable alterations. Our PD-L1's high at 70%. And so began frontline carbo-pembro regimen that you've made famous there, Delvis, and did well initially with a partial response, but then did show progression after about 3 months in the liver. And so now we're talking about second line after frontline chemo IO. What are our second line options? Delvis, what are you reaching for today off study in a second line setting?
Well, it's quite interesting because, unfortunately, we are still seeing this kind of patient in our clinic. Even if chemo plus immunotherapy work, I would know that a lot of them relapse and are resistant to therapy at the beginning. And the standard of care for this patient is docetaxel plus nintedanib plus ramucirumab as you prefer if it's in non-squamous histology. But especially in the rapidly progressive patient, we combine with nintedanib in non-squamous in Europe. But it's a standard of care, it's docetaxel, and that's okay.
So I'm in Korea, second line here for you?
Yes, I think I agree with Delvis that outside of trial, we are still stuck with docetaxel, which has a response rate of less than 20% and highly toxic in patients. When we give them 4 to 6 cycles or above, patients experience so much toxicity with docetaxel. So I think you're still in here.
But I would say something because all of us know that docetaxel response rate is around 8-10%. But it was in the era before immunotherapy. We are seeing right now that those patients who receive immunotherapy before and they get treated. And it worked not only for docetaxel, but also for the ADC, because maybe the response rate will be different in those phase 3 trials that we are waiting right now, comparing anti-TROP2 versus docetaxel, because all the patients receive immunotherapy before. And we need to keep this in mind.
We do. So docetaxel is still our standard of care. We've been saying that answer for decades. See Paul Bunn here in the front. Been saying second line dosi for too long. Clearly, we need something better because not only is the response rate low, the ceiling's low, it's the toxicity. It's a tough drug.
It's true.
And we really sacrifice a lot of quality of life with some of our older cytotoxic. Is this a setting where ADCs will make an immediate impact, Sunman?
Yes, I think so. So I think we're waiting for TROPION-Lung01 phase 3 data in the second line setting. So when we have the data published, I think we'll have the answer for that because that's comparing docetaxel versus Dato-DXd 1-to-1 in the randomized phase 3 trial data. So we'll have to see if it'll change our treatment paradigm.
Yes, I think everybody wants to remove docetaxel from the.
But it's going to be more than just efficacy, all right? And so it's also going to be safety. We know the toxicity of docetaxel. We're familiar with it. It's why we don't like giving that drug. But the ADCs have their own toxicity. Delvis, why don't you walk us through some of the notable toxicity with sacituzumab?
Yes, as I said before in the previous trial that I showed, the toxicity with the sacituzumab, because I have to say that I think everybody are afraid with the pneumonitis when we are talking about ADC. And with the sacituzumab, this kind of toxicity is low. But you have other toxicity, gastrointestinal effect like diarrhea or neutropenia. It is high. It is. We have to educate the patient. For this, we have to say exactly in the first week, please keep attention. If you have fever, you have to come to do a blood test. And that's all with diarrhea also, because we need to take water, to have all the pre-medication or all the medication the patient start with diarrhea. We have to keep hydrated, and that's, for me, that's the two more important toxicity that we need to keep in mind where we will treat the patient with sacituzumab.
Yeah.
Especially those. And I would like to say that, especially, but we saw in the trial, in the phase 1/2 trial with sacituzumab, that those patients with UGT were homozygote. All of them, 90% are heterozygote, but around 10% could be homozygote. And for those patients, this kind of toxicity could be higher. For all topoisomerase 1 inhibitor, I recommend it to keep in mind this. We use it with irinotecan in the practice in colon cancer and the rest of the disease. Why not to use it and to be compulsory in this kind? For me, these two adverse events are the more important for sacituzumab, that you have to educate the patient.
So, with many of these drugs, we see some myelosuppression. We can see alopecia. Important to warn patients about that. But with sacituzumab, because the payload is that active metabolite of irinotecan, we're looking more at these irinotecan toxicities. And so diarrhea, neutropenia, those are the important ones to watch for. And you mentioned earlier, ILD, less of a concern with this agent, right?
Yeah. But also, I forgot, but it's good to say, it's a less toxicity, but alopecia is also here, and vomiting. And it's some kind of toxicity, especially vomiting or nausea, that you have to can alter the quality of life of patients if you don't manage properly this kind of.
Now, the pneumonitis, which fortunately is a lot lower here, we do see it not very high rates, but we do see it with the other TROP2 ADC, right, Simon?
Yes, that's right. So with Dato-DXd, you see a higher incidence of pneumonitis, as we have seen before in the doublet combination, 17% all-grade pneumonitis, 22% in the triplet regimen. So if we experience pneumonitis, it's quite troublesome and quite worrisome for the patients, because even at grade 2, per guideline, we should discontinue permanently the drug. And what do we do with grade 1 asymptomatic pneumonitis? Do we just re-challenge the drug? We don't have the answer for that right now. I think that will be released this year, in ESMO this year. So ILD is a notable toxicity that we have to pay attention here. And I would suggest that this DXD payload has a higher incidence of developing ILD, but we don't know exact mechanism behind that. Who will be more likely to develop ILD, and who have the risk factors for ILD?
Yeah, the toxicities with all these antibody drug conjugates, we got to consider the payload, which is responsible for a lot of that, but also the antibody, because that's going to localize that toxicity. And those are the on-target but off-tumor toxicities that we worry about. So it's really important we familiarize ourselves with these. They don't need to dissuade us necessarily from using these agents. We just need to know what to watch for so we can anticipate, so we can properly manage the toxicities here. There's some really good questions here. First question here, Sun Min, do the TROP2 targeting ADCs show CNS activity in lung cancer?
Oh, that's an interesting question. I would like to know that answer too. But I think, those patients with CNS disease, in theory, we don't think that this big molecule such as ADC could penetrate this BBB. However, those patients with brain metastasis have leaky BBB, so we might expect some CNS activity in these patients. So we don't have the intracranial activity data yet, so we'll have to watch for that.
Yeah, we've seen irinotecan is a drug we use in CNS tumors, and so the payloads may make a difference here. But we've also seen with trastuzumab deruxtecan, again, a big molecule, so you wouldn't expect it to work, but we have seen CNS responses in breast cancer. And so I think that the jury's still out. Doubles?
Yes, I'm completely agree, but we have behind as the college to treat breast cancer, because I was talking with them and I said, wait, I have some patient with anti-TROP2 and with brain met in breast cancer and are responding also.
Yes,
I completely agree with you that when you think in antibody, it was the same with immunotherapy at the beginning. You think in the molecular and you think it's very big to enter in the brain, but it's not necessary that, because the payload is small, is a metabolism very active, and the immune system is activated in some way. And I think we need to see all the data, the real data in lung cancer, but I'm confident that it will work somehow.
This is an interesting point here. Delvis, we'll start with you. There's evidence that TROP2 expression can change over time, that in about a third of patients after treatment with chemotherapy or radiotherapy, it can alter. So they're asking, what are the potential implications of these changes in TROP2 expression after first and second line treatment? And is that going to influence where we use these?
That's a very good question, but really, there is one study that said that after chemo radiotherapy, the expression it doesn't matter very much, Steven, and that's great, and that's good, and that's why maybe we still without using TROP2 like a biomarker, but I don't think that we need to do a rare biopsy and to see the expression of TROP1 after chemotherapy or after radiotherapy. We have data that this expression change, but not too much like in other tumor and other biomarkers.
Yeah, I think we need to look at these data, but when we look at frontline, second versus later lines, it might eventually sort of tell us where these drugs wind up.
I insist that we need to find other biomarker. I don't know which one is going to be related, but we have to move in all medical oncology and be the same. Try to find.
All right, this is a great point, more of a comment, I think. Sacituzumab has a drug antibody ratio of 8, whereas datopotamab has a drug antibody ratio of 4, but the payload, DXD, is a more potent payload than SN38. So how do you compare these two molecules that are head-to-head? What are your thoughts here, Samir?
It's hard to compare just the numbers. I think if you dial up more toxicity, I don't think so. So I think that even though datopotamab has a SN38, it's more potent than those of the
It is true. It is true. The payload is potent with the datopotamab and the number is small. But SM38 have another particular things also when entered. It's a small metabolite, very active also inside the cell. You know, it's difficult to compare face to face.
It is. I think the right answer is you can't. You can't compare them head. They're different drugs. But there are two questions here. I'll try to get to the heart of this. It's more of a direct question here. If both drugs are available, how are you choosing one over the other?
That's a good question. we need to see the result, the follow-up. That's what I think some mean. I don't know.
I agree.
I'm concerned about the day 8 with sacituzumab and the pathological toxicity in that day, if we have to control or not. How is the result? But we need to wait and to see the phase 3 trial that is running right now, that is close, waiting for the result. What do you think?
Yeah, I think so. Both strategies are on the way, first line, second line, and we have very little evidence so far that the ADC can replace chemotherapy. So many different strategies are ongoing. So I think we'll need to wait for more durable long-term responses and data.
Yeah, I think it's a good question. These two drugs are different, right? So they have different schedules. It's true, we'll see what the indications are, but they have different toxicity, right? And that's going to influence a lot of our treatment. And we'll see what these data look like. And we'll look at more than just response rate. Are some of them working more of an additive level, and are some working more synergistically, improving long-term outcomes? So data is still pending here. This last question, I think we're going to run out of time. Last one, though, and this is a good one. Can we use these in sequence? If you receive one and develop resistance, can you go to the other? What do you think, Salid?
Well, the acquired resistance to ADC is a hot topic, and I think it needs more investigation and research. So there are many mechanisms proposed for the acquired resistance. So the target down regulation and the payload resistance, many different mechanisms of action, but we don't know yet in real patients. So we don't have the pre and post biopsy samples to compare the target levels. I think that should be done in prospective clinical trials afterwards.
No, I'm completely agree. We don't know. The answer is we don't know.
Yeah, but maybe. It depends on resistance. And if there is resistance tailored to the payload, is it tailored to the antibody? And so in theory, possibly, but we got to do those studies. We should do those studies. So we are out of time at the top of the hour. I'll make sure we keep everyone on schedule. Thanks everyone for joining, and thanks to our my panelists here, Dr. Delvis Rodriguez Abreu, Dr. Sun Min Lim. Thank you for being here. Thanks for joining us.
Thank you. Yeah.
Thank you.
This activity is certified by PVI, Peerview Institute for Medical Education. Remember to download the slides and practice aids.